Good afternoon, everyone. I am happy to present my progress in my research in treatment of acute ischemic stroke. I am Esra Zhubi. I'm a medical doctor, and I'm a PhD student at the Department of Neuroscience in Semmelweis University. Here you can find our research team. My vision is to make early stroke treatment available for everyone and have disability-free patients. My mission is to make a meaningful impact on stroke prevention and treatment through innovative methods. Here you can find our two projects which we aim to complete through the methodology of systematic review and meta-analysis. Our first project is investigating the predictive role of flare positivity on clinical outcomes after intravenous thrombolysis in non-onset stroke. In 2019, there were more than 12 million incident cases of stroke and more than 100 million prevalent cases of stroke. Intravenous thrombolysis remains the key treatment for the stroke. However, it can lead to complications such as hemorrhagic transformation and therefore cause neurological deterioration. Magnetic resonance imaging and fluid attenuated inversion recovery, or as known FLAIR, can play a crucial role in predicting clinical outcomes after IVT in stroke patients. For those not familiar with acute ischemic stroke, in MRI, here is an image where there is a lesion which is immediately visible in the DVI, but in the first part, it is not equally visible in the flare. In the second imaging, there is a lesion that has appeared in the DVI, but also flare. So this is the difference between flare negative and flare positive lesions. These differences or this mismatch has been used in detecting strokes that are within the standard window of treatment. And therefore find the patients who are still eligible for treatment, especially in the wake-up strokes, because the lesion in flare usually appears after the standard time window. However, there are cases when the lesion also appears within the standard time window, which implies that the stroke is more severe. There is the vasogenic edema already developed due to the disruption of the blood-brain barrier. So our aim is to evaluate whether flare positivity predicts worse clinical outcomes after intravenous thrombolysis in non-onset strokes. Our clinical question is, does flare positivity predict worse clinical outcomes among stroke patients who undergo IVT within the standard time window? So this is the population is these patients who undergo IVT within the standard time window. We will compare the flare positive and flare negative lesions, and we will look up for two outcomes, the hemorrhagic transformation and less favorable 90-day functional outcome, which we measure through the modified Rankin score. We hypothesize that flare positivity is predictive of worse clinical outcomes in stroke patients undergoing IVT within the standard time window. Here is our systematic search, which we conducted in 3 databases, and we got almost 10,000 studies, which by title abstract selection and full text selection, we achieved to include 6 studies in our meta-analysis. We have completed our analysis in hemorrhagic transformation. However, we are waiting for the results of less favorable 90-day functional outcome. Here you can see the results, the forest plot of our first outcome. In the 4 involved study, the hemorrhagic transformation was defined as the presence of the hemorrhagic lesion in the imaging, which was a CT or MRI 24 hours after the IVT. So we included 4 eligible studies, and they both had the flare positive and flare negative acute ischemic lesion patients involved. From the number of the events in both groups, we can see that in the first group, in the flare positive groups, there were almost 35% of the patients had a hemorrhagic stroke, whereas in the second group, almost 15% of the patients had a hemorrhagic transformation. There was a high heterogeneity between studies, which tells more about the difference in the measured effects in the involved studies. We measured the odds ratio, which tells us that the odds of having a hemorrhagic transformation were 3 times higher in the FLAIR-positive group. Although we did not reach statistical significance, we think that our results have a high clinical significance. So the strength of our study is that it is the first meta-analysis done on this topic through the methodology of meta-analysis. It has a high clinical relevance. However, there was a high inter-study heterogeneity. There were a limited number of studies that we could involve, and our studies were retrospective cohorts, so we didn't have any RCTs or prospective cohort studies to involve in our analysis. Based on the results of the first outcome, we can conclude that FLAIR positivity is predictive of worse clinical outcomes in stroke patients who undergo IVT within the standard time window. Our implication for practice is that FLAIR can be used as prognostic tool and can help in risk stratification of patient and can make a treatment decision support. However, this does not imply that we should exclude the patient with FLAIR-positive lesions from the IVT treatment, but this prognostic tool should help us in the follow-up treatment after the IVT. Implication for research is that we need to do more prospective studies. We should include more data for the other factors within the MRI, and therefore explore more novel prognostic tools and their follow-up studies for the impact of these treatment modifications. This is the progress of our first project. We are waiting for the second table, and therefore we will continue with the grade and manuscript. Our second project is comparing combined intravenous and endovascular therapy and endovascular thrombectomy alone in acute posterior circulation strokes. PCS are associated with severe neurological impairments and the potential risk of fatality. If they stem from the basilar artery, they can exhibit morbidity and mortality up to 95%. As IVT yields insufficient acute reperfusion rate, EVT is the most promising therapeutic option for large vessel posterior circulation strokes. Recent studies have shown that bridging IVT and EVT results in higher reperfusion rates and better clinical outcomes. Our aim is to compare these two treatments in the treatment of large vessel posterior circulation strokes. Our clinical question is, does combined IVT and EVT result in better clinical outcomes than EVT alone among acute posterior circulation stroke patients? Our population is acute posterior circulation patients. We will compare these two therapies, and our outcome will be 90-day mortality, 90-day functional outcomes, symptomatic intracranial hemorrhage, and successful reperfusion rate. We hypothesize that combined therapy is better and is superior to the EVT alone. If we are to prove our hypothesis, the results will have in modification of treatment of stroke patients and decrease in mortality rate in the posterior circulation strokes. This is our final search key, and we conducted the search in 5 databases, and we ended up with more than 6,000 studies. We registered our protocol in Prospero, we removed the duplicates, and now we will start with title and abstract selection. To summarize, we plan to finish our 2 projects during this year. I would like to thank you for your attention and would like to finish the presentation with a quote by Miller Fisher: "We learn neurology stroke by stroke." Thank you.
Thank you for this nice presentation. Regarding your first project, I'd like to ask you if you only examine the FLAIR pictures regarding the MRI parameters, or you also did examine other MRI parameters, I mean diffusion imaging or perfusion deficit or something else?
Yeah, thank you. We looked closer at the studies to see whether we can also check to the other like DVI lesion volume or flare vascular hyperintensity and also use them for other analysis. But the studies were so diverse, like one study involved all of them, the other involved only flare hyperintensity. So there was not a uniform type of data that was used in this study. So it was the only data that we could have. It was about flare positive and negativity, and the only outcomes were hemorrhagic transformation and functional outcome.
And I suppose all of them were large vessel occlusions, right? Because
not in the first study.
Did you do a subgroup analysis regarding the stroke territory, for example, whether if it was a posterior stroke or anterior stroke? Was there any difference between these types, for example?
In the first study, the type of stroke were not large vessel occlusion because they were treated only with intravenous thrombolysis. And there was no data that showed the location, or there was no grouping of the patients based on the location of the lesion. So they were, let's say, a bit superficial with this data, the involved studies.
Do you use this method, I mean, regarding to the first project of flare positivity in the clinic?
It is not used as, I mean, I actually explained that the flare positive lesions within the standard time windows show you that the stroke should be more severe, should the blood-brain barrier is already disrupted and the vasogenic edema is already developed. But there is not like a guideline or a general consensus that this, and it's not actually practiced, not for my knowledge, or at least in my country.
Okay. Thank you. Do you have any data on the core to needle time? So the phone call from the patient and to the needle of the thrombolytic agent.
Yes, we extracted that data too. Not every study reported it, but we saw that there was, because we extracted those data to compare the sample of each study and see what was the reason that the other one study had higher rates of hemorrhagic transformation, or as we can see in Hobom, the study in the here. This one has a much higher rate of hemorrhagic transformation. When we compare the time from lost known normal to imaging, or from imaging to treatment, or lost known normal to treatment, there was no huge difference in any of the studies. Also, they had the same group age, like 55 to 85 years old patients. So there was no difference in that meaning. The only difference that we could find between studies was that Hobom, the National Institute of Health stroke scale, the patients in the Hobom group had a higher NIHSS, which means the patients that were involved had a more severe stroke, and therefore they had a, that's why what we have concluded so far, but we will explain further in the study. That was the only difference. All four of them used MRI 1.5 Tesla before the IVT. After the treatment, 24 hours after the treatment, they used MRI, except Hobom, who used CT. So these are the only two differences.
Okay, thank you.